Sir, we can. Yeah,
Yeah, I think we can start. So the Shigellosis now is a big problem, at least in Kerala, even in Kerala. And so, what are the clinical features and management in children? The children are the commonest people that is affected by Shigellosis. Almost, if the world over, almost 100 million cases of Shigellosis are there per year, and almost 6 lakhs deaths annually. And if you see, the majority of people who dies due to Shigellosis is children, less than 10 years. Very young children, especially from infants, sometimes maybe because of the important anti-immunity immune factors that is there in breast milk, they'll be escaping that death. But mainly, majority of children are below 5 years also. And as discussed earlier, the usual timings are rainy season in tropical climates and warm months in temperate climates. And majority of the massive epidemics are caused by Shigella dysentery type 1. And what is the importance of Shigellosis is they survive in low gastric pH. So that will bypass the gastric pH and reaches distal colon. That is the target organ. So you can even develop distal colitis or pancolitis. And they invade colonic epithelial cells via M protein. And some species, that is the most dreaded problems, that we are seeing so many cases when we were in Calicut Medical College, so many cases are having encephalopathy. So these are mainly caused by Shiga toxin that is produced by Shigella dysentery type 1. What are the clinical manifestations? So that was discussed earlier. How we can diagnose that probably this is a case of Shigella or probably this is a case of viral diarrhea. That is very difficult sometimes. That may be the reason why some people will get over treatment and some people won't give antibiotics properly. So this is very difficult in some cases. So we should have an algorithm, but algorithm also may be slightly difficult. Whenever we are facing a Shigella epidemic, so we should, and there is a cases of Shigella in the vicinity, there we have to think of Shigellosis much more common than we are dealing with a case of viral diarrhea. So Shigella dysentery type 1 produce severe manifestation and incubation period is very less. It can be as less as 12 hours to several days. And the infectivities, they are highly infectious, as small as 10 bacteria can produce Shigellosis. Unlike Vibrio cholerae, 10 raised to 10 can produce a Vibrio cholerae. The common features, how to differentiate between a viral and Shigellosis. Usually fever is a common problem. Viral diarrhea won't produce severe fever. And whenever a child is having severe high fever and toxic in an epidemic of Shigella, so we have to think that this child may be having Shigellosis. Abdominal cramps, tenesmus, abdominal pain and tenesmus is very important. And child will be having vomiting and rehydration and electrolyte imbalance also, anorexia. And the peculiar thing is that usually they may manifest even as diarrhea initially, and dysentery occurs later. Blood in stool occurs after 1 or 2 days. And usually the diarrhea occurs for 7 to 10 days. At least in 10% of children, they may last for more than 10 days. So many children, the persistent diarrhea occurs in a malnourished children, children with immune deficiency, children with diabetes, or children with any chronic systemic illness like tuberculosis, HIV infections. They may develop persistent diarrhea. Usually, that is self-limiting. And whenever you see a child with Shigella, always there will be high fever, toxicity, abdominal distension, tenderness, hyperactive bowel sounds, tender rectum, and even in malnourished children, you will get rectal prolapse also. And this is the most important thing for Shigella, that is extra-intestinal manifestations. Unlike viral diarrhea like rotavirus and all, the neurological features are very common in Shigella. That is called as Shigella encephalopathy. Sometimes that may even present before diarrhea. That was in the previous talk. The speaker was telling at least one case child was having Shigella encephalopathy earlier, then diarrhea later. That is now very common also nowadays. Child will present with fever and features of encephalopathy, tiredness, And then the child, after admission, the child will develop diarrhea, then the child will develop dysentery also. So at least 40% of children will have neurologic finding early. So whenever there is a neurologic finding and a diarrhea, the most important one to distinguish from others is Shigella. And Shigella toxin, that is mainly the neurological findings are mainly caused by Shiga toxin, that is derived inflammatory mediators like tumor necrosis alpha and interleukins that can produce all the features of extraintestinal manifestation. The child may come to you with high fever, headache, convulsions, lethargy, confusion, hallucination, and nuchal rigidity. And all these things can be called as Shigella encephalopathy. Another thing is metabolic complication. Dehydration is very common in Shigella and hyponatremia. So Shigella can produce inappropriate ADS secretion along with usual cause of sodium loss. It can produce severe hyponatremia that can even produce convulsions later. So serum sodium less than 126 millimole per liter, and hypoglycemia, hypocalcemia, and severe protein losing encephalopathy producing little bit edema in the lower limb, sepsis, DIC, they are common in Shigella. And even after infections, even after the diarrhea settles, they can produce complication. And the common dreaded complication is hemolytic uremic syndrome. And they can produce reactive arthritis, irritable bowel syndrome. And the fatal Ikiri syndrome, I think few cases was described from Calicut by Dr. Jayakrishnan, Ikiri syndrome. They present with convulsions, hyperpyrexia, brain edema, headache, and the mortality is high in Ikiri syndrome. So this is the problem in diagnosing Shigella. So that is very difficult to diagnose. If you make an algorithm, very difficult to diagnose between diarrhea from usual rotavirus or other viral diarrhea, which doesn't require antibiotics, and Shigella that requires antibiotic very early. So whenever a child is coming from an epidemic or any area where Shigella is reported, and if the child is unusually toxic, febrile, and having abdominal pain, tennis pus, and of course, it is very clear if there is blood in stool and features of encephalopathy, so we can suspect Shigella. And investigations, fecal leukocytes, more than 50 polymorphonuclear leukocytes per high power field. There is a blood in feces. And if there is a peripheral blood leukocytosis, that all will add to the diagnosis. And sometimes there will be blood counts will be elevated. But the diagnosis is culture of stool and rectal swab. Now the molecular methods like PCR have a high negative predictive value. If we have that facility, that will be well and good, and we can diagnose early and we can tailor our treatment. Regarding treatment, first thing is correction of fluid and electrolyte balance, just like any other cases of diarrhea, because this Shigella will produce dehydration, Shigella will produce hyponatremia, Shigella can produce hypoglycemia also. And all textbooks says vitamin A single megadose will be helpful. Zinc supplementation, 20 milligram for 14 days. That is a usual diarrhea treatment management that also we have to give in children with Shigella. Nutrition with high protein, high calorie, and less bulk, because Shigella can produce the malnutrition later also. If the child is already having malnutrition, that can produce persistent diarrhea. Then antibiotic policy. So if you are so now this is a double-edged sword. Nowadays I have seen many cases of even viral diarrhea without much toxic features. They are giving oral antibiotics. And as it was discussed earlier, sometimes in a case of Shigella, we may even give antibiotics later also. But whenever a child is not having much features of Shigella, it is better to withhold antibiotics and give ORS, give fluid and electrolyte balance, and you can give zinc also. So we can wait for antibiotics. But if the child is having toxicity, features of encephalopathy, severe dehydration, and of course, whenever there is 10% blood in stool, you have to start antibiotics. Which antibiotic we have to start? So all over the world, all Shigella is almost resistant to amoxicillin, ampicillin. and even quarter amoxicillin. So we cannot use amoxicillin, ampicillin, and quarter amoxicillin in Shigella dysentery as a first choice. And even first and second generation of cephalosporin, cephalexin, cephadroxil, all these things are ineffective for Shigella. So we are left with mainly third generation cephalosporins. So ideally, we should have a sensitivity pattern of that area. I think we can plan about which is the organism, which organism is sensitive to these cases now after getting all this culture and sensitivity report. But as such, oral cefixime is a good choice. 8 to 10 milligram per kilogram body weight divided into 2 doses for 5 days is the treatment duration. And if the child is admitted and if the child is very toxic and if the child is having features of encephalopathy, you can give ceftriaxone injection. 50 to 100, we will give 100 milligram per kilogram body weight per day, either OD or divided into 2 doses for 5 days. And which is next choice, suppose the child is not responding. So what, as per the guidelines, we are saying whenever you are giving oral cefixime or ceftriaxone after 3 days, or after we are getting a culture and sensitivity report, and after 3 days, if the child is not responding, we can add a second line of drug. Ciprofloxacin is used. The dose is 20 to 30 milligram per kg per day, divided into 2 divided doses for 5 days. But we are not giving ciprofloxacin as a first line drug because there are a lot of, so there are some studies that say that there is some chance of arthropathy in the children. That is only for long-term use, but still we can keep ciprofloxacin as second line of drug. Then azithromycin. The dose is 12 milligram per kg per day orally for day 1, followed by 6 milligram per kg per day for 4 days. Total duration is again 5 days. This is the usual drugs that is given for Shigella. And prevention, we were discussing prolongation of breast milk. Actually, breast milk will give much protection for Shigella. That may be the reason why the Shigella is very less in infants compared to older children. And proper hand washing. So mainly our mothers, after using toilet, we have to advise. That's one thing that should be very clear is after using toilet, they have to wash hands. Before cooking, they have to wash hands. That is also 2 things that they will forget. And in our children, diaper changes. After every diaper changes, you have to wash the hands, wash and clean the hands. Then next thing is raw vegetables like salads and all. We have to wash the raw vegetable thoroughly. That is second thing. And prevent intake of possible contaminated water and immunization. No, there is no immunization for Shigella as such, but the routine prevention of diarrhea by immunization, by measles, by rotavirus, we have to strengthen these immunization programs. Thank you. This is in short how the clinical management and some guidelines for managing a child with Shigella. Thank you.